τα λόγια σας. It's my now distinct honor and high privilege to introduce our very distinguished panelists of the first masterclass of this Ocular Oncology Happy Hours, Prof. Carol Shields and Prof. Aaron Siggy, each of them pioneered in the field of ocular oncology. We will be discussing today about intraocular tumors in adults. And the first speaker would be Prof. Carol Shields. And it's a great pleasure for me to introduce Prof. Carol. Between all the rest, has been named as the first on the ophthalmology priority list by ophthalmologists in 2020. Has been named since 2014 in the Castle Connolly American's Top Doctors, American's Best Eye Doctors, named since 2014 as one of the top 100 ophthalmologists worldwide, the power list, and in 2011 has been received the Academic All-American Hall of Fame prize for who has achieved lifetime success in their professional careers, just to mention some of the awards of Prof. Carol Shields. She has been an inspiration for each one of us, and for me, I cannot thank her enough for her mentorship all over these years. Prof. Carol Shields, we're all looking forward. Thank you, first of all, thank you very much for, it's an honor for us, for you to be here this afternoon, and we're all here today to listen all the recent updates on uveal melanoma 2022.
Thank you, Dr. Pevkianaki. It's a great pleasure and honor for me to speak to you and your fellow members in the Greek ophthalmology world. I have financial disclosures as I serve on the Scientific Advisory Board for ARA Biosciences and Immunocore. So in the next few minutes, I will talk to you about uveal melanoma 2023, and we will talk about 4 subsets: melanoma identification, genetics, treatment, and prognosis 2023. So let's begin with melanoma identification. Sometimes it's easy to find a melanoma in the eye, especially when the tumor has a nodule, is over 3 millimeters in thickness, and has overlying orange pigment. But it's not always that easy, because there are pseudomelanomas that simulate melanoma, such as this patient that I saw 3 months ago, who came in with a bilobed melanoma, at least that was what he was referred with, but it proved to be hemorrhagic pigment epithelial detachment with subretinal hemorrhage from age-related macular degeneration, and we treated him with anti-VEGF injection rather than melanoma treatment. And sometimes it's difficult, as in this doctor who came to see us. This doctor was told he had a melanoma in his left eye, in the far periphery. And you can see there is a pigmented mass, and it looks like it's elevated, but it's not elevated at all. And on autofluorescence, it's completely hypo-autofluorescent, consistent with congenital hypertrophy of the retinal pigment epithelium. This was a birthmark, not a melanoma. This was CHRPE with a pigmented halo, making it look elevated, but it was completely flat. No treatment was necessary in that case. Now, sometimes if a melanoma is large and with episcleral sentinel vessels, and you can see it on ultrasound at 17 millimeters in thickness, you can't miss it. But you have to rule out other conditions like hemorrhagic retinal detachment and uveal effusion syndrome, and even metastatic disease. It's even harder to find melanoma when it's small, because it resembles choroidal nevus. And we like to identify risk factors like orange pigment that you can see on the autofluorescence, or subretinal fluid that you can see on the OCT as risk factors that predict this pigmented lesion in the left paramacular region is really a melanoma. So I show you 4 cases here. 3 are nevi and 1 is a melanoma. Now, you can't tell just by looking at the lesion in most cases. It's important to get imaging testing like autofluorescence and OCT, and most important, ultrasound. And in this case, the upper right lesion had an echolucent ultrasound, strongly suggestive of a melanoma and not a nevus, whereas the other 3 were classic nevi with echo-dense ultrasound. How common is choroidal nevus? Well, in the Blue Mountain Eye Study from Australia, 1998, Archives of Ophthalmology, Sumech et al. Said choroidal nevi was found in 6.5% of the white population. We did a similar study in the United States, Mary Q and I. We looked at the NHANES database at the CDC in the US and published this in Ophthalmology 2015. We found choroidal nevus was present in 5% of US adults. But honestly, a little secret, I think this is an under-representation of choroidal nevi because in the NHANES database, they only took 2 fundus photos, each small angle, and they missed about 70% of the fundus. I think choroidal nevus is even more common than 5% of the US adults. So we push for early detection of choroidal melanoma and differentiation from more common choroidal nevus. And it's important to know that smaller, thinner choroidal melanoma has a better 10-year prognosis than medium thickness and than greater thickness of choroidal melanoma. And we showed this in a publication, Archives of Ophthalmology 2009, where we looked at metastatic disease from uveal melanoma based on millimeter by millimeter increase in thickness in 8,000 consecutive eyes with uveal melanoma. We found one simple answer in this report. Every millimeter that a melanoma increases in thickness causes an increased rate of metastatic disease at 10 years by 5%. So, for example, if a melanoma is 2 millimeters in thickness, it has a 10% risk for Mets by 10 years. And if it's 4 millimeters in thickness, 4 times 5%, it has a 20% risk for Mets by 10 years. And we constructed this table, and this is an important table, looking at millimeter increment in thickness of uveal melanoma on the left, and then on the right, the 10-year Kaplan-Meier estimate of metastatic disease. Now, you and I aren't going to remember every single millimeter increase in thickness, but we like to think of melanoma as small, 3 millimeters or less in thickness. That has a 15% risk for metastatic disease at 10 years. Medium, 3 to 8 millimeters in thickness with a 30% risk for metastasis. And large, greater than 8 millimeters in thickness with a 50% risk for metastatic disease by 10 years. This is really dangerous disease, and identifying melanoma when it is small is important. So how often does choroidal nevus transform into melanoma? Well, it's uncommon. It's less than 1% in the real world. So how often does choroidal nevus transform into melanoma in our practice, where we see very suspicious lesions, or in the practice of Dr. Pethkianaki, where she sees highly suspicious choroidal nevi? Well, our practices are not the real world because we see very suspicious nevi. But we published this report in Retina 2019, choroidal nevus imaging features in over 3,000 cases, identifying risk factors for growth into melanoma. And in this series of 3,800 cases in an oncology practice, ocular oncology, we found 1% of choroidal nevi transform into melanoma by 1 year, 6% by 5 years, 14% by 10 years. So it really happens, and it's more common in our practices of suspicious choroidal nevi. And we identified risk factors that help us to find the nevus at risk for transformation into melanoma. And it's easy to remember these risk factors. On the left, you see our mnemonic to find small ocular melanoma doing imaging. This mnemonic helps us to remember the letters of each variable, TFSOM, DIM, which represent thickness over 2 millimeters, F for fluid on OCT, S for symptoms of vision loss on the vision chart, O for orange pigment on autofluorescence, M for melanoma hollow on ultrasound, and DIM for diameter greater than 5 millimeters on fundus photography. These 6 risk factors create a risk for transformation of nevus into melanoma. And the greatest hazard ratio or greatest risk was with thickness over 2 millimeters, then fluid on OCT, and orange pigment on autofluorescence. And I always tell the doctors and fellows that I'm working with, the big 3 are thickness over 2 millimeters, fluid on OCT, and orange pigment on autofluorescence. We always get ultrasound, OCT, and autofluorescence on all choroidal nevi because we want to identify risk factors. Altogether, if a patient has all 3 of those risk factors, the hazard ratio is 67 times greater risk for transformation into melanoma compared to a nevus that doesn't have those risk factors. So very simplistically, if a patient has no risk factor, there's only a 1% rate of growth in 5 years using Kaplan-Meier. If a patient has any one risk factor, there's an 11% rate of growth. Any 2, a 22% rate of growth. Any 4, greater than 50% rate of growth. And we use this as our cutoff. If we see a choroidal nevus that has 4 or more risk factors, TFSOM, DIM, then we will treat it promptly rather than waiting for growth. So let's look at this lesion smartly. Let's use risk factors: thickness, fluid, symptoms of vision loss, orange pigment, melanoma hollow, and diameter greater than 5 millimeters. And you can see in this lesion, it was less than 2 millimeters in thickness on ultrasound, but on the autofluorescence, there's bright orange pigment. And on the OCT, there's subretinal fluid. That would be the F. And the O is the orange pigment. This patient has 4 of 6 risk factors. This is a lesion that has greater than 50% rate of growth. This is probably a lesion that one would consider prompt treatment. So each combination gives a unique risk. We published in British Journal of Ophthalmology 2018 all the combinations of risk factors. There were greater than 60 combinations of these 6 risk factors, and we constructed a heat map of each specific combination, whether it be just one factor, all the 2-factor combinations, 3, 4, 5-factor combinations. And then we scored the rate of transformation into melanoma. So the blue and green colored columns are low risk, and the hot colors, the orange and the red, are high risk. And here you can see all the high risk red lesions. These are 70% or greater risk for transformation into melanoma. Some of them had 100% rate of growth. So we can identify very high risk lesions and treat promptly. We think this heat map will play into future artificial intelligence. And I think what we're going to be doing is scoring each nevus with a relative score of 0 to 100 based on the combination of risk factors. So use risk factors to score a nevus, and if 3 or 4 or more, consider it could be a melanoma, as in this case. This patient had 4 risk factors, prominent orange pigment and subretinal fluid. This was a melanoma and not a nevus. Moving on to genetics. There's a lot going on with melanoma genetics. Basically, we sample the melanoma with a tiny 27 gauge needle and send it to a genetics lab, and they either look at the DNA or the RNA to identify if the tumor carries bad mutations. And with DNA, chromosome 3 and 8 mutation are poor prognosis. With RNA, a class 2 gene expression profile is poor prognosis. And those patients with poor prognosis are at high risk for metastatic disease, and we promptly enter them into adjuvant treatment trials. And I think you should know about the National Cancer Institute in Washington, D.C., created the Human Genome Atlas and then created the Cancer Genome Atlas, where they looked at 33 different types of cancers, including 10 rare cancers, one of which was uveal melanoma. And they looked at the molecular basis of the cancer, subtypes, and therapeutic targets, including uveal melanoma. And what they found with uveal melanoma, this large report was published in 2018. They looked at 80 cases from different centers across the United States with a multi-platform molecular analysis and found 4 distinct subsets based on genetics. One subset was those with disomy of chromosome 3. They called it Group A and Group B. And then the other was monosomy of chromosome 3, Group C and Group D. A and B low risk, C and D high risk for metastatic disease based on genetics alone. So we took the Cancer Genome Atlas and applied it to 658 patients with uveal melanoma to see if it truly was predictive of metastatic risk. And then later, we looked at 1,001 cases based on the Cancer Genome Atlas with longer 10-year follow-up. Published this in Indian Journal of Ophthalmology. And what we found was, yes, it was highly predictive of risk for metastasis based on genetics alone. Group A had low risk. The green columns are 5-year rate. The blue columns, 10-year rate of metastatic disease. So Group A and B had low risk for metastasis, whereas Group C and D had high risk for metastasis. Again, based on those 4 groups, A, B, C, D, which were based on genetic mutations. So in our practice, we use DNA analysis because it's less expensive than RNA analysis, and it's what most European countries use. And if a patient has Group A or B genetics, good prognosis. If it's Group C or D, poor prognosis, and we enter them into systemic trials to prevent or reduce metastatic disease. And the same is done if RNA is used for gene expression profiling. If it's classified as Group 2 or Class 2, then they're entered into systemic trials. So what is the risk if we follow a borderline choroidal nevus and it shows growth into melanoma? Well, I'm going to quote this very interesting article from the Saudi Journal of Ophthalmology 2018, where Dr. Pevkianaki was one of the lead researchers. So we looked at choroidal nevus growth into melanoma. Do these patients have good or bad genetics? Well, what we found was it's inversely related to the speed of growth. In the 55 patients with choroidal nevus growth into melanoma, if the growth was fast at less than or equal to 1 year, then 80% of patients had Group C or D, high risk for metastatic disease. But if the growth was very slow, greater than 1 year, as Dr. Pevkianaki discovered, then this was less risk for metastatic disease. Only 38% were high risk. Most of them were low risk for metastatic disease. And this was highly significant. And we showed illustrations. Here's an example of slow growth. When we saw the patient, and 69 months after, you can see there's a little tail of tumor growth, but it took many years, low risk for metastatic disease, whereas this only took 3 months, high risk for metastatic disease. And our team of geneticists have looked at even additional genetic alterations, where we looked at 921 primary tumors and found a small subset of patients who had significantly higher rate of metastasis. This small subset only represented 7% of all patients with uveal melanoma, but they had a mutation on chromosome 1p or 16q, and 88% of them developed metastatic disease. We're looking into this small subset and why this happens. Okay, moving on to melanoma treatment. We have many different ways to treat uveal melanoma. We can treat with enucleation, plaque radiotherapy, proton beam, stereotactic radiotherapy, gamma knife radiotherapy, and this is available right there in Greece, cyberknife radiotherapy, and other methods. I'll speak on plaque and the new method, RNA nanoparticle therapy. So plaque radiotherapy has been around since really the late 1920s, but really popularized in the 1970s. Very effective for treating uveal melanoma. Here's a 9 millimeter thick uveal melanoma before and after treatment. Plaque radiotherapy in our hands offers 98% local control. Only 2% of patients fail and need enucleation or second plaque. But there are complications with plaque radiotherapy. The radiation can cause a retinopathy, a papillopathy, a choroidopathy, cataract glaucoma, and even scleral necrosis. So how can we reduce the retinopathy or even the papillopathy? Well, we've looked into prophylactic anti-VEGF, and it works. We've looked into bevacizumab because it's low cost, giving bevacizumab every 4 months for 2 years after plaque of uveal melanoma. We looked at over 1,000 cases, and we found prophylactic bevacizumab every 4 months for 2 years offered significantly better visual outcome. And if you compare the 1-year vision, mean vision, in the bevacizumab group was 20/40 versus control, which was 20/60. It still was significant. But if you look at 2 years, it's 20/50 versus 2100. And 3 years, even though the patients are off bevacizumab, they have still significantly better vision, 20/60 versus 2200. And then at 4 years, again, off bevacizumab, because we only give it 2 years, the vision was better in the bevacizumab group, 20/70 versus counting fingers. This paper was published in JAMA Ophthalmology 2020, and a commentary was written on it. And basically, Bolt et al. Wrote in their commentary, this is good data, but let's evaluate it in a prospective fashion. So we're now moving ahead along with Dr. Singh and our team and other centers in the United States to have a prospective analysis in the diabetic retinopathy retina network under the direction of Dan Martin. So this is all new, and hopefully within the next few years, we will have some information that we can give you about our prospective trial, where we're going to compare long-acting steroid versus anti-VEGF versus sham treatment. Now, I want to talk to you about a new melanoma therapy, ARA-011 nanoparticle therapy. We've completed phase 1b/2 study in 56 patients, looking at different doses and complications. Basically, this is for treatment of small choroidal melanoma, small melanomas that show signs of activities or risk factors. And this is a viral-like nanoparticle. that is injected into the vitreous cavity. It's coupled with a photosensitive drug, and it's attracted to the melanoma. And then we shine a laser light into the eye that causes immediate necrosis of the tumor and also stimulates an immune response, which is something that we want to look into because we wonder if it might be protective of metastatic risk. This was FDA approved in March 2017. There are several centers now in the United States using this, and this will soon be in Europe in our new trials that are upcoming. Basically, in the first trial, we found that most patients will show a little bit of anterior chamber and vitreous inflammation in over 70% of cases, but it responds to steroids. Vision loss is very little, only 4% lose vision. This is significantly less than plaque radiotherapy, and it's related to tumors in the fovea that develop RPE modeling. And tumor control is about 70%, and this medication is effective in halting tumors with documented growth. But now we're looking at a better way to deliver this medication through suprachoroidal injection, and the trial has already started. We deliver the meds by suprachoroidal injection and shine the laser light into the eye. This phase 2 trial with 17 patients, single dose and dose escalation. Thus far, we've had no dose-related toxicities and no serious adverse events. And at the American Academy of Ophthalmology this year, I will be speaking on tumor control and visual outcome in this suprachoroidal delivery arm of ARA nanoparticle therapy. So last, let's talk about melanoma prognosis. Well, prognosis is really based on genetic results and a little bit on tumor thickness. And we already talked about the genetics. Groups A and B, good prognosis, and groups C and D, poor prognosis with high risk. 10-year risk for group C, almost 50% get metastatic disease. 10-year risk for group D, over 60%. And these patients are treated with adjuvant sunitinib, a protein kinase inhibitor, valproic acid, or ImmTAC. I want to tell you a little bit about ImmTAC. You may or may not have heard about this. ImmTAC is an immune therapy that was just FDA approved 2 months ago for the treatment of metastatic uveal melanoma. ImmTAC stands for immune modulated T cells against cancer. It's uveal melanoma specific. It redirects T cells to fight cancer using cell surface markers. It's like we're educating the T cells to identify the melanoma metastasis. And what happens is it's a bispecific molecule. It has an HLA-A2 receptor that's attracted to the uveal melanoma. And then it has a CD3 receptor that brings in the T cell. So the T cell is held onto this molecule and redirected to the melanoma. And once it reaches the melanoma, it's activated and it causes melanoma metastasis, death. Here you see a lady who had liver metastasis, multiple bright signal round lesions in her liver. Without treatment, she would have lived maybe 3 or 6 months. She's now 7 years follow-up with complete tumor resolution with ImmTACs. Now, ImmTACs has a generic name. It's called tebentafusp. And D'Amato et al. Published in the journal Cancers 2019, ImmTAC at 2 years had 70% success in saving patients' lives with uveal melanoma compared to all other therapies, which only had survival of 20%. That was the first indication that this treatment might be beneficial. So it's called tebentafusp. And again, tebentafusp made it to the New England Journal of Medicine 2021. Our representation was Marlana Orloff, underlined in red here, where we all looked at tebentafusp, and Paul Nathan wrote this report on the overall survival benefit of tebentafusp for metastatic uveal melanoma. Most of us call this medication now Tebi. We don't use that long name. We call it Tebi. And Tebi was compared to any drug the melanoma oncologist wanted to use. So it was Tebi versus any medication for metastatic uveal melanoma. And at 1 year, the overall survival was 73% for Tebi versus 59% for all other medications. And that was significant. But Tebi does come with side effects. And the number one side effect is dermatitis. It causes all the melanocytes in the body to become a little bit inflamed. But these side effects are controllable. So Tebi demonstrated significant improved overall survival compared to really good medications like pembrolizumab and ipilimumab and dacarbazine. So Tebi is effective, but it requires a weekly infusion, and it can cause an autoimmune storm, and you need to be very smart when you deliver Tebi to the patient, and our oncologists don't really know when to stop. But we're looking at Tebi in different ways, not just to treat metastatic disease. How about using it as an adjuvant? For example, how about if we see a patient that's a group C or D, high risk for metastatic disease? Can we use it to prevent metastatic disease? Well, this trial is already designed and will be performed in Europe. And can we use Tebi in a neoadjuvant fashion? Say we have a large tumor and we give Tebi to shrink the tumor to a medium or a small size, and then maybe we can irradiate or even use our nanoparticle if we get the tumor small enough. That's neoadjuvant Tebi. So we're looking at new ways to use this very effective drug. And we will be studying this in the City of Brotherly Love in Philadelphia. We are going to be investigating neoadjuvant use of Tebi. So there's much more to explore with Tebi. And if you look online, you might find its trade name is now Kimtrac. So over the past few minutes, we've talked about melanoma identification. Remember the risk factors to find small ocular melanoma doing imaging. Be smart when you see a choroidal nevus. And if you're not sure if it's a melanoma, I would say let Dr. Pevkianaki make the decision, because you don't want to miss a small melanoma. Melanoma genetics are really important. We use the Cancer Genome Atlas, ABCD, that was described from the National Institute of Health in Washington, D.C. Melanoma treatment, radiotherapy, whether it's plaque radiotherapy or gamma knife radiotherapy, cyberknife, proton beam. Radiotherapy is very important for melanoma treatment, but so is this new medication for small melanoma, our nanoparticle. And then prognosis. Well, we give adjuvant treatment to patients who are at high risk for metastatic disease, and now Tebi has entered the arena for treatment of uveal metastasis and hopefully for prevention of uveal metastasis. There's a lot of exciting future for the management of uveal melanoma now that we have an effective immune therapy. I'd like to thank all the organizers of this happy hour ocular oncology session, and I'd like to give special thanks to Dr. Maria Pevkianaki for including me as one of the speakers. Thank you.
Thank you very much, Dr. Carol. Great lecture, as always. So I've got a question for you. I know that you mentioned in your presentation today, but just for the general ophthalmologists that right now are watching us, how we could identify risk factors for nevus growth to melanoma?
Yes, so in our study, when we looked at 3,600 choroidal nevi, we found those that grew, and then we looked at all the factors that predicted growth. So we identified these 6 factors, as I said in my talk. I think when a general ophthalmologist sees a patient with a choroidal nevus, they should think, well, it's very rare for nevus to grow to melanoma, but it's a good idea to get a picture, maybe once a year, and
Mm-hmm.
maybe get an ultrasound just to get a thickness on the lesion. And if it's over 2 millimeters in thickness, that's when you start getting into doing autofluorescence or OCT, or maybe, send the patient into an oncology center where they might be able to better, assess risk factors for growth.
Okay, thank you. And I've got one more question. So you mentioned about TEBI, the new approved medication for uveal melanoma metastasis to liver. How do we plan to explore the use of TEBI to neoadjuvant and adjuvant settings? If you can tell us a bit more about that.
Sure. So you might say, why don't we use the standard immune therapies like, pembrolizumab or ipilimumab? Because they don't work. They only 4% of patients with metastatic disease show a response to those really good checkpoint inhibitors. So we can't use them, but they're used for skin melanoma because they work with skin melanoma, but they don't work with uveal melanoma. Now that we found an immune therapy, TEBI, we're going to be using it in 3 different ways. Number one, we're already using it for treatment of metastatic disease, and it works. But it's challenging to give an infusion every week. So we're working on better ways to deliver it. Number two, it's going to be used in the adjuvant setting. So patients who have large melanomas or genetically bad melanomas will probably get TEBI for a defined period of time to see if we can reduce the risk for metastatic disease. Very exciting. And then lastly, in Philadelphia, we're going to take a few patients with large melanomas and see if we can shrink the tumors down with TEBI and hopefully at the same time reduce their risk for metastatic disease. That's called neoadjuvant, as I mentioned in my talk. So we're looking at many different ways of using this new medication. And trust me, TEBI doesn't work for every uveal melanoma. Only 40% of patients have the right HLA cell surface marker. So we're also talking to the company about making TEBI more broad spectrum so that it can be attracted to all uveal melanomas so that all patients can benefit from this. So exciting things going on in the field of uveal melanoma and remote control of metastatic disease.
Thank you so much, Carol, for explaining that so well, and we got an idea about this new approved medication. We're looking forward also for your results of your research. And I know now that you are a speaker also for another webinar, so I leave you. Thank you so much for joining us this afternoon. It's a big honor for all of us, and personally for me.
Thank you very much. And good luck with your center. And you should be very proud of your country of Greece. You could build a wonderful center. I know that when we started our center here in Philadelphia, it was, the whole field of oncology was just starting. And now our center is very strong. And Dr. Singh has a very strong center in Cleveland. It will happen with the support of your community.
It's so nice to hear those words from a person, for a mentor, a big mentor. Thank you very much.
Okay, thank you and good luck.
Thank you.